Have you ever seen an angel? Yes, flying around with wings. Do you want to see an angel? If you want to see an angel, you can. Yes, how can you do that? Just stand in front of the mirror and you will be seeing one. Yes, not all angels have wings. Some angels have stethoscopes. And these are the angels that we want. And you are one of them. We start with a very, very important topic, and that is fungal sinusitis. And with the advancement of the knowledge about what fungus does in the nose, with the advancement of knowledge about fungal sinusitis, this topic has become very, very important. And recently, there are so many questions on fungal sinusitis. Moreover, with COVID, yes, this has become even more important. So now, before we start this topic, let us quickly first try to understand what at all can fungus do in the nose and how does the fungus reach there. So just listen to this carefully. Whenever we are breathing normally, if by chance there is fungus in the air that we are breathing in, the fungus goes inside. Now, while we are breathing out, the fungus can come out also. Yes. Now, it is also a possibility that the fungus gets entrapped in the sinuses and it does not come out, it remains there. Now, if it remains there in the sinuses, then the response will depend upon what the fungus will do there, will depend upon the immunity of the patient. Is that absolutely clear? The response will depend upon the immunity of the patient. If the patient is immunocompetent, the immunity of the patient is good. And at the same time, if the patient is not allergic to that fungus, so that fungus will stay in the sinus and slowly grow there. Okay. And that is what we call as fungal ball. Now, if the patient in whom the fungus has gotten trapped in one of the sinuses is a highly allergic patient, the patient is atopic, the patient is allergic to that fungus. So now the patient's immune system will elicit a very severe allergic reaction to the fungus. That is what we call as allergic fungal sinusitis. And if the immunity of the patient is low, if it is an immunocompromised patient, then that same fungus becomes invasive in that patient and it leads to what is known as invasive fungal sinusitis. So what we are seeing is that fungal sinusitis can be either non-invasive. Non-invasive can be either just a fungal ball, or it can be allergic fungal sinusitis, or it can be a invasive fungal sinusitis. Okay, so it can be non-invasive or it can be invasive. Non-invasive can be either fungal ball or allergic fungal sinusitis. Now let us see each one of them one by one. So let us first see what a fungal ball means. Now, as I have already told you that when the patient inhales the fungus and by chance the fungus gets entrapped in the sinus and the patient is of good immunity, patient is immunocompetent, also the patient is not allergic to the fungus. Now what will happen is that the fungus will stay there and it will slowly grow. So as it grows, all the accumulation of the fungus leads to the formation of a structure like a ball. That is what is known as fungal ball. And when it grows further till it is like a small fungal ball, patient will not have any symptoms. Now when it grows further, it will now lead to obstruction of the osteometal complex area and then the patient will have features of sinusitis. So this patient will come to you with the features of sinusitis, nasal obstruction, nasal discharge. Yes, patient will have facial pain, hyposmia. And when you examine the nostril, what you will see on endoscopy is an appearance like this. The appearance is a cheesy clay-like debris you might be able to see in the middle meatal area. And when you will get the CT scan done to confirm whether it is a fungal sinusitis or not. So what you see on CT and how will you confirm by that? Yes, this appearance is very much confirmatory. You can send this for a fungal smear and yes, CT is almost diagnostic. And what you see in CT here is, can you see these areas? These areas of heterogeneous opacities? Yes, so this fungus has a characteristic that it entraps metals. It entraps which metals? Yes, it entraps iron, it entraps calcium, it entraps manganese. And this appearance of heterogeneous appearance is what on CT is what is known as appearance on CT is what is known as the double density. It is known as double density sign. Double density, also known as rail track appearance. Rail track appearance. Rail track appearance. So what are the important things that we need to know in the fungal ball? Yes, what is the fungus that most commonly leads to fungal ball? Yes, it is Aspergillus. Aspergillus. Yes, each one of this is a question of your exam. Okay, so now what is the immunity of the patient in whom fungal ball develops? I have told you that the fungus goes into the sinuses. Now, what the patient will develop next depends upon the immunity of the patient. Yes. So, who will develop fungal ball? A patient who is atopic? No. A patient who is immunocompromised? No. A patient who is immunocompetent. Patient who is immunocompetent, and at the same time he is not allergic, he is not atopic. So atopy will be absent. How is the presentation? Yes, as I have told you earlier also in the previous module also, but yes, I will tell you again here that whenever the fungus goes and it gets entrapped, that is just a by chance that the fungus has got inhaled and by chance it has got trapped. So it is not necessary that if it gets trapped, it has to get trapped in both the nostrils, in both the sinuses. Yes. So usually it is a unilateral condition. Rarely it can be bilateral, but usually it is unilateral. And which is the sinus where fungal ball is seen most commonly? Yes, we saw that in the previous image. Did you see here? Yes, it is seen most commonly in the maxillary sinus. Can you see here? The ethmoid is clear here. Yes, so it is unilateral. And again also notice is it unilateral? Yes, it is unilateral. And it is unilateral, and the most common sinus that is involved is maxillary. What is the appearance of the endoscopy? What appearance do we see of the fungus? Yes, it is a cheesy clay-like debris. And CT, what you see is the double density. The double density sign. So now you have confirmed that this is a patient of fungal sinusitis having a fungal ball. How will you manage this patient? Yes, the first thing is that the patient will come to you only when it's symptomatic, right? Which means that now the fungal ball has enlarged to involve the osteometal complex to block it. So we will have to open the osteometal complex. We will have to remove this foreign body. What foreign body? The fungus which has gotten trapped there, along with all the fungal hyphae and all the block and all the debris that has collected. We will have to clear it. And once we have cleared it, we have to restore. We have to widen the ostia of the maxillary sinus so that the ventilation and drainage will be restored. So what is this surgery known as? Yes, you do it with the endoscope. Functional endoscopic sinus surgery. Is there any role of antifungal? Do we give antifungal? No. Why? What has happened is that there is an external fungus which has got and it is sitting there and it is not invading the mucosa. When you get the biopsy done, when you send it for histopathology, you will see that it is not invading the mucosa. So all you have to do is, it is extra mucosa, so just remove it completely. Once you have removed it completely, you have removed the foreign body. You have removed the external factor. Nothing needs to be done. No antifungal need to be given here. So the management is FES and no need for antifungal, just FES. Let us quickly see how the fungal ball and the cheesy clay-like material of the fungus looks like. So now let us quickly see FES being done in a patient of fungal sinusitis. This patient has a fungal ball in the right maxillary sinus. So let us quickly see. So this here is the septum and that is the lateral wall. So we can see the suction now in the middle meatal area. And yes, we can see the fungal ball being suctioned out from the middle meatal area. Yes, and this is not all of it. Once uncinectomy is done, we will clearly be able to see the maxillary sinus ostia, where we will be able to see much more. So yes, the uncinectomy has been done, and we can see the exact appearance of the fungal ball, the cheesy clay-like appearance filling the maxillary sinus. That is the most common location of fungal ball. Yes, it is unilateral, and we are going to clear the maxillary sinus completely of all this fungal material. And once it is clear, yes, the ventilation and drainage has been restored, and no need for any antifungal. Just a fess will suffice for the management here. Now, if the patient in whom the fungus got entrapped is an atopic patient, yes, the patient is an atopic patient. Now, what will happen is that the patient will, the immunity will react against that fungus. The patient is allergic to that fungus. There will be a very severe allergic reaction to that fungus, and that severe allergic reaction will lead to a lot of eosinophils in the discharge, and that eosinophils will make the discharge a very sticky, thick appearance of discharge that will block the osteometal complex and lead to features of chronic sinusitis. Yes, and later on what will happen is, because of constant very severe allergic edema and obstruction of the osteometal complex area, polyps will develop in this patient. So patient will come to you with what complaint? Yes, patient will come to you with a complaint that there is nasal obstruction. One side, both the sides. Yes, usually it will be unilateral. As I told you, that it is not necessary that it has to get entrapped on both the sides. Usually it will get entrapped on one side. So yes, patient will have unilateral nasal obstruction, and when you examine, what you see in the nose is polyps. So yes, when we did polyps in the nose, did we do that any unilateral polyps in adult should be investigated for fungal sinusitis, allergic fungal sinusitis? Yes. So what you examine in the nose is polyps, right? So the fungal sinusitis, which is non-invasive, can be either a fungal ball or it can be a allergic fungal sinusitis. Allergic fungal sinusitis, and the presenting features is nasal obstruction, and when you do endoscopy, what you see is nasal polyps, and very, very important on endoscopy is the thick mucinous sticky nasal discharge. This is known as mucinous discharge, mucinous nasal discharge. And yes, this is a repeatedly asked question. In any question, the moment you see mucinous word is given, the answer is allergic fungal sinusitis. Whatever they must have asked, either the diagnosis or the management, it will be allergic fungal sinusitis. So mucinous nasal discharge. And yes, this mucinous nasal discharge, when you try to suction, with the suction, you will see that it just comes out like a string. It is very difficult to suction it out. And this is what is known as a peanut butter. The appearance is known as peanut butter or axle grease appearance, It has a thick, sticky and a very dirty appearance, appearing like peanut butter or axle grease. So yes, what we are seeing here are the mucinous secretions typical of allergic fungal sinusitis. Yes, just see how with the suction it is getting pulled out like a string. Whenever you are seeing mucinous secretion or it is mentioned in your question, immediately you have the answer with you, and that is allergic fungal sinusitis. That is because of the excessive eosinophils in the discharge that makes it mucinous. And now your suspicion is high that this is a patient of allergic fungal sinusitis. Why your suspicion is high? Because of the nasal polyps, because of the mucinous discharge, because of the history of allergy that the patient is giving. So now when you go for the CT scan, what you see in the CT scan again is the heterogeneous appearance. Now you will tell me what this appearance is known as. Yes, it is known as the double density. Also, it is also known as the rail track. Sometimes it is also known as the starry sky appearance. And also please note one thing. Can you see here that which is the most common sinus that is involved here? Yes, see here we have the ethmoids here. Yes, this is of a child. So here maxillary sinus, we are seeing this is a very anterior cut. In the anterior cut, maxillary sinus is not seen very clearly. Now just see again here, can you see that it is unilateral? It is here we have the maxillary sinuses. All this is involving the ethmoid here. Yes, so the most common sinus that is involved here is ethmoid sinus. And yes, please note here that also what you can see is that there is so much of expansion. The septum is pushed on the other side. So yes, this mucin is expansive in nature. So it is expansive in nature. What's the significance of me telling you that this is expansive in nature? When the sinuses expand, the walls might get thin, very thin, and there can be erosion. There can be also erosion of the lamina papyracea area because that is already very thin. And in the ethmoids, it is seen most commonly. So when you're seeing an erosion and you're suspecting allergic fungal sinusitis, don't think that this is invasive. Yes, erosion can occur, though it is rare, but yes, erosion can occur, and that erosion is not because of the invasiveness of the fungus. That is because the mucin, the allergic mucin is expansive in nature. And the cause of this double density sinus, entrapment of metals, because of entrapment of metals. So what are the things that we need to know in allergic fungal sinusitis? Yes, what is the most common organism that causes this? Yes, here it is. It is not aspergillus, it is demataceous fungi. Demataceous fungi like curvularis, bipolaris, alternaria. The immunity of the patient, what is the immunity of the patient? Is it immunocompromised patient? No, don't confuse that, okay? It is immunocompetent, but a atopic patient. So this is immunocompetent, but it is an atopic patient. So atopy is present here. What will be the presentation of the patient? Presentation will be like chronic sinusitis. This will cause obstruction of the osteometal complex, will have the complaints of nasal obstruction, nasal discharge, facial pain, hyposmia. And when you see on endoscopic examination, what you see is polyps with mucinous nasal discharge. And the patient can also tell you that the discharge that comes out from the nose is a very thick, sticky discharge. So in presentation also, the mucinous nasal discharge history can be present. So yes, there can be history of mucinous discharge. So yes, polyp with mucinous discharge on endoscopy, and the most common sinus that is involved here is ethmoid. So now you have confirmed, when the patient has come to you with these features, that this is the patient of allergic fungal sinusitis. Now for the diagnosis of allergic fungal sinusitis, there should be 5 points that should be present in the patient, and they are known as the Bent and Kuhn criteria. Diagnostic criteria given by Bent and Kuhn of allergic fungal sinusitis. And all these 5 major criteria you need to know. There are minor criteria also. What is the major and what is the minor criteria? Now we will see the major criteria first. Major criteria is what you need to remember. Minor criteria, even if you do not remember, it is okay. Why? Because for the diagnosis, all the 5 points of the major criteria should be present. Minor criteria just adds on to the diagnosis, but even if it is not present, that is perfectly okay. So what we need to remember very, very nicely is the major criteria, and that is exactly what we have seen. Yes, what was this? That this was a atopic patient, so IgE levels are raised. What is the examination finding in the nose that you get? Yes, you see nasal polyps. And along with that, what you see is mucinous nasal discharge, that is eosinophilic mucin. We know that mucinous discharge is because of the lots of eosinophil which is present there. So eosinophilic mucin. And when you get the CT scan done, what you find on the CT scan is the double density or the heterogeneous appearance. Also known as double density sign. We have written this so many number of times. And what is the 5th point is that when you take a nasal smear for a fungal smear, that turns out to be positive. So the fungal smear is positive. Now the minor criteria, even if you do not remember, it is okay, but I will just tell you what the minor criteria are, and yes, it is easy to remember. I have just grouped it accordingly so that you can remember it with each of the major criteria. So Ig levels are raised, right? So along with that, you can remember that if Ig levels are raised, it is an allergic patient, then he will also have asthma. Right, so asthma will be present. If the patient has nasal polyps, what is usually the presentation? Is it unilateral or bilateral? Yes, so usually it is a unilateral presentation. So unilateral presentation is one of the minor criteria. Rarely it can be bilateral, but usually it is unilateral. Eosinophilic mucin, with this you can remember the minor criteria as serum eosinophilia, serum eosinophilia. And also, what are the breakdown products of eosinophils? Charcot-laden crystals. So, Charcot-laden crystals are present. Now, CT shows the heterogeneous appearance, and on CT there can also be bone erosion. Is this because of invasion? No, because of the expansive nature of the allergic mucin. So there can be bone erosion, and fungal smear. With fungal smear, you can remember fungal culture is positive. Fungal culture positive. So with each one of the major criteria, you know, is associated another criteria, and that is a minor criteria. Minor criteria, if you forget, perfectly okay. Major criteria, you have to remember. So when all these 5 are present, we have diagnosed that this is a patient of allergic fungal sinusitis. So how are you going to manage this patient? Yes, are we going to give some antifungals to the patient? It is a fungal sinusitis. Now, has the fungus invaded here the mucosa? No. So, no need for antifungal. All you have to do is, we know that external fungus has got entrapped and that is leading to all this problem. So, what we need to do is just remove that fungus. Remove that fungus and open up the openings of the sinuses so that the sinus is now properly ventilated and it can drain all that obstruction that was occurred because of the mucin, because of the fungal debris. Just remove everything. The allergic factor is the fungus. Remove everything. How will you remove that? Yes, by endoscopic sinus surgery. What is that? FES. So what you do for the management is you go for FES. Functional endoscopic sinus surgery. The management is surgical. And in the post-operative period, we give steroids in the form of nasal spray. Sometimes maybe a short course of systemic steroid might be given if there is a lot of edema inside the nose. And antifungals are not required unless and until it is a very severe disease or the response is not good of surgery. Only then. So antifungal is usually not required. So if required, in which cases, if the response is not very good, then we can go for iatroconazole. Now, this is what the response will be of the fungus if the patient is immunocompetent. Is that very clear? If the patient's immunity is good, what type of fungal sinusitis will the patient develop? Quickly tell me. Yes, if the patient is not atopic, fungal ball. If the patient is allergic, atopic, allergic fungal sinusitis. Quickly tell me the 5 Bent and Kuhn criteria, diagnostic criteria. Yes, first, Ig levels raised because it is an atopic patient. When the patient has come to you on nasal endoscopy, what you find? Nasal polyps. Along with discharge, mucinous discharge. How do you confirm it? CT. CT, what do you see? Double density sign. And when you send the smear for culture, yes, it will be positive for fungal smear. Very good. So you have done a FES for this patient. Now, if this is a patient who is immunocompromised, now what will happen is this fungus will become invasive, and that is what we call as invasive fungal sinusitis. So if the patient is immunocompromised, so then the patient will develop acute invasive fungal sinusitis, and this invasive fungal sinusitis can be either invasive aspergillosis, which is caused by Aspergillus fumigatus, or it can be very, very important, mucormycosis. Mucormycosis is caused by Rhizopus and mucor. So what happens is that this fungus is Okay, now both of these are angioinvasive. Angioinvasive means it immediately invades the endothelium of the blood vessels. It reaches the blood vessels and there it causes thrombosis. And because of the thrombosis, now it leads to ischemia. So there it is an angioinvasive fungus. It invades the endothelium of blood vessels and leads to thrombosis of the blood vessels. Thrombosis. Now because of thrombosis, now what occurs is ischemia. And because of ischemia, then results necrosis. Necrosis. And this necrotic tissue appears as a black eschar. So wherever this fungus is spreading, this is angioinvasive fungus. So this is very, very fast spreading. It spreads very fast spreading, and that is why it is life-threatening. That is why it is life-threatening. Why life-threatening? Because immediately from the nose, in no time, in hours, it will go into the sinuses, and from there it is angioinvasive. So it will go into the orbit, it can go intracranially, and you can lose the patient in days. Yes, so that is why you have to be very, very careful. You cannot miss this condition at all. So what we have to be careful, in which patients do we have to suspect that this is a fungal sinusitis, the invasive fungal sinusitis, mucormycosis? Yes, the patient has to be immunocompromised. Is that clear? The symptoms will be exactly like sinusitis, and that was creating all the problem in everybody during COVID. Everybody wanted to get tested for a mucormycosis, for black fungus. Yes, it is known as black not because of the black appearance of the fungus, but because of the necrotic eschar. Yes, why everybody wanted to get them tested? Because the features are like sinusitis, and sinusitis is so common. So as a doctor, will you inspect every patient? Will you get an endoscopic examination and a CT scan examination, and will you try to rule out mucormycosis in every patient who has come to you with features of sinusitis? No, remember that invasive fungal sinusitis occurs only when the patient is immunocompromised. Is that absolutely clear? Yes, immunocompromised. So what are the high risk population? Which are the people in which we have to be on a lookout and we have to have a high index of suspicion? Yes, so what are the high risk? Yes, the primary is diabetics. Yes, why in diabetics? Because in them, the hyperglycemia reduces the chances of phagocytosis. And also, it causes dissociation of iron. And iron is a very important component required for the growth of the fungus. So very, very important is the diabetics, where the diabetes is not controlled, where the sugar is not controlled, uncontrolled diabetics. Now here, again, very important factor for forming the high risk is the people who are taking steroids. We saw that the management of COVID was with steroids. So there were many people who come into the high risk. So why steroids lead to immunocompromise? Yes, because they unmask the underlying hyperglycemia, and that reduces the immunity, reduces the phagocytotic action. Now, very important for the growth of the fungus is iron. So people who are taking iron, elevated levels of free iron, or people who are getting treatment with desferrioxamine, they are again, they comprise the high risk group. And another high risk group is the people who are on immunosuppressants because they have received a transplant. So either a bone marrow transplant, yes, or a solid organ transplant, or people who are having hematological malignancies, people who are having neutropenias, leukemias. All these are the people who comprise the high risk population. So if these people present with features of sinusitis, only then we have to rule out an invasive fungal sinusitis. Is that absolutely clear? These are the people whom you will take up for an endoscopic examination. So a non-endoscopic examination, what you find is discolored black areas. Yes, discolored black necrotic areas. Black necrotic areas. Necrotic areas, and because of those black areas, it is what is known as the black fungus. Necrotic areas give it the name of black fungus. Okay, just see here. Here you can see so much of necrosis inside the nose. And immediately in no time, can you see? Yes, it can spread from the nose. It can go into the paranasal sinuses. It can go to the orbit. It can go intracranially. So it can go to the paranasal sinuses. It can go to the orbit. It can go intracranially. It can go below to the palate. Yes, and all this can occur through intravascular because it is angioinvasive, intravascular. This spread can also be perineural or it can be a direct spread. Now, when it goes to the orbit, what are the symptoms that it will cause? Yes, it will lead to blurred vision. That is a very early symptom. It can lead to proptosis. It can lead to chemosis. It can lead to complete ophthalmoplegia. So it can go to orbit where these will be the presentation, and there were so many patients who had a little blurred vision also just because of a nearsightedness or because of anything, just came with a complaint that they wanted to get ruled out for a mucormycosis. So do we have to take whatever they say into account and get them investigated? Not unless and until they are immunocompromised. Is that very clear? Only in immunocompromised. So it can go intracranially, and there the presentation is very bad. There it can lead to altered mental status. It can lead to headache. It can lead to cranial nerve palsies. It can also involve the cavernous sinus, which is almost lethal. It can involve the palate, where people have loosening of teeth and necrotic ulcers over the palate. Here is a patient who has come to you with the features of sinusitis, and yes, it is an immunocompromised high-risk individual, and you are seeing that maybe there can be loosening of teeth, there can be black necrotic areas on endoscopy, blurred vision. Now, how are you going to confirm that this is mucormycosis? Should you go for a CT scan then to confirm it or not? Yes, this was another thing that we saw during COVID, that there were so many patients who by themselves got a CT scan done, and they came to you with a CT scan for what? For what purpose? They wanted you to see the CT scan and tell you whether it is mucormycosis or not. So can you just see the CT scan and tell that yes, this is mucormycosis? No. CT scan will be exactly like features of sinusitis. Maybe what you will be able to see is erosion if you are able to see, but most of the time you will not be able to see that also. All that you are able to see is just features like sinusitis. Yes, mucosal thickening. You will be able to see mucosal thickenings. You will see air fluid levels. So how then do you confirm that this is mucormycosis? It is invasive fungal sinusitis. Yes, you go for microscopy. So what you see on microscopy is, diagnosis is by microscopy. Yes, what you see on microscopy is ribbon-like aseptate fungus which are branching at right angles. And also you sent the specimen for histopathology, and what you find on histopathology are infarcts, angioinvasiveness, and perineural invasion. Yes, and if the microscopic result will be with you very soon. So you will not wait for the culture report to come, which will take at least 3 days. Immediately, the moment on microscopy it is confirmed that this is an invasive fungus, you have to start the patient on the treatment. So once you have diagnosed this, you immediately start the patient on the treatment. And what is the treatment? Yes, the treatment comprises of 3 main modalities. Yes, what is the 3 main modalities? You will immediately first start the patient on the antifungal. Which antifungal do we give here? Yes, we give the patient IV amphotericin B. The one that we use is liposomal IV amphotericin B. So yes, the first thing that we do is we start the patient immediately on IV amphotericin B. So liposomal amphotericin B. Amphotericin B, and this is given in the dose of 5 milligram per kg per day, and the dose is higher, around 7.5 to 10 milligram per kg per day in CNS involvement. In invasive aspergillosis, we can go for voriconazole. So in invasive mucormycosis, the first management is immediate starting of IV amphotericin B. Is that clear? Only in aspergillosis, if on microscopy what you are seeing is aspergillosis, then you can start the patient on voriconazole. Now at the same time, you immediately post the patient for surgical debridement. A very good surgical debridement needs to be done, and the surgical debridement has to be done till there are clear bleeding margins, which means that all the area that is thrombosed has been removed. So once there is bleeding margins, means that is the healthy tissue, all the necrotic tissue has been removed. Now why do we need to debride? Why are we debriding? Yes, we are debriding because all the necrotic area acts as a nidus for the growth of the fungus. And also once we have removed all the necrotic area, we have removed the burden of the disease. So now the drug will have less tissue to act upon. So the result of the medication also will be good. So that is along with it. It is not that you first do this, then this, then this. So all this 3 treatment has to be, the multimodality treatment has to be together. So you start the patient, immediately you post the patient for surgical debridement, and at the same time, don't miss out not correcting the immunocompromised status. Whatever the patient has immunocompromised because of, that needs to be taken care of. Otherwise, no matter what treatment you give, the patient will not respond. So that is a very, very important. The rapid reversal of underlying immunocompromised condition has to be done. Now, once the patient is properly being treated and the response of the patient is very good, the response we see by getting serial radiological investigation done. Yes, the radiological investigation is not for diagnosis. Is that very clear? The features are exactly like chronic sinusitis, but radiological investigations are done for 2 reasons. First is to see the extent of the disease, and second is to see the response of therapy. Once you have operated in that area, to again see that area endoscopically and to be able to find out whether it is responding or not is not very easy in operated cavity. So what we do is, for seeing the resolution of infection, we go for serial CT scans done, and that will show the resolution much better than on endoscopic examination. So the radiological investigation is for first to note the extent of the disease, and second to see the response for therapy. Response of the therapy. So once the patient has been treated, the response of the therapy is good. Now you can send the patient on isavuconazole and on posaconazole. Do we need to give any prophylaxis to the contacts? They will ask you that, is it a contagious condition? In my family, there are 2 people who are having this condition. There is 1 person who is having this condition. So can I also develop? Yes, so these are the questions that patients will ask you. Is it contagious? No, it is not contagious. Yes, so can any prophylaxis be given to those who are contacts? No. Second, is any prophylaxis required for people who are high risk? They will ask you, I am high risk, I am a diabetic, uncontrolled diabetic, I am taking steroids. Yes, so should I take prophylactic treatment? No, there is no role for prophylaxis for anybody, either high risk or for contacts. Is that very clear? No role of prophylaxis. Yes. So there are certain myths about mucormycosis. First, and yes, you should know this with COVID prevailing. These are the questions that anybody might ask you. Is it contagious? No, it is not. Yes, in fact, each and everything about mucormycosis is very, very important and you should be knowing. Even when COVID was not there, almost every year there was some question on mucormycosis. But now more so, the reason that it can be asked. It is an opportunistic fungus. So all the people who are not high risk should not be unnecessarily investigated for this condition. And yes, it is not black, because of which it is known as black fungus. It is known as black fungus because of the necrotic areas. So what we know of fungal sinusitis as of now is that the fungus gets entrapped in the sinuses, and now what the patient will develop depends upon the response of the body of the person in whom the fungus has gotten trapped. If the person is immunocompetent and non-atopic, what will he develop? Fungal ball. If the patient is immunocompetent but the patient is atopic, what will he develop? Allergic fungal sinusitis. In fungal ball and allergic fungal sinusitis, what will be the appearance of the CT? Yes, double density sign. Mucinous appearance, if you are seeing in nasal endoscopy, what is that? That is allergic fungal sinusitis. If you are seeing cheesy clay-like material, yes, then that is what? That is fungal ball. Now, if you are seeing black necrotic areas on endoscopy, then it is invasive. So, if the response of the patient, if the patient is immunocompromised, then what will be the sinusitis that the patient will develop? Fungal sinusitis. Yes, that will be invasive fungal sinusitis. And in invasive fungal sinusitis, if it is invasive aspergillosis or a mucormycosis, yes, the presenting features will be exactly like sinusitis. So which patients we have to take care? We have to be on a high suspicion, only the high risk. Yes, in them when we get endoscopy done, what we see on endoscopy? Black necrotic areas. Is CT done for diagnosis? No, CT is done for, yes, to evaluate the treatment response and also to see the extent of the disease. What is the main management of mucormycosis? Yes, the main management is first start the patient immediately on IV amphotericin B. Is it angioinvasive fungus? Yes or no? Is it life-threatening? Yes, it is life-threatening. So you have to start the patient immediately on IV amphotericin B. And yes, along with that, surgical debridement, along with that, the underlying pathology which is leading to immunocompromise must be taken care of. Now, also there is another variant of invasive fungal sinusitis, and that is what is known as chronic invasive. What we saw now, the mucormycosis or the invasive aspergillosis, they present acutely. Yes, within hours to days, they progress very severely. Whereas there is another variant of invasive fungal sinusitis, that is chronic invasive fungal sinusitis. And this chronic invasive fungal sinusitis is also known as granulomatous fungal sinusitis. This is caused by Aspergillus fumigatus or Aspergillus flavus, and it is seen more commonly in certain areas like in India, in Pakistan. It is seen in Saudi Arabia. And is it seen? It is invasive, right? So is it seen in immunocompromised patient? No. This can be seen in immunocompromised. It can also be seen in immunocompetent. Usually here the patient is immunocompetent. So it is usually immunocompetent, or maybe some degree of compromise might be present, or sometimes compromised also. Sometimes immunocompromised, Usually it is immunocompetent. And what's the presentation? It is not like the acute fulminant presentation. Within hours to days it is spreading. It is not like this. It spreads very slowly. Initially there are features of chronic sinusitis. Later on there will be little proptosis, or there will be mass in the cheek. Yes, so one of my chemists, his wife had this condition. Yes, it is seen in India, and it is, as I have told you, that it is seen more commonly in India and Pakistan and Saudi. And actually, we see patients here of chronic invasive sinusitis. Yes, what she had the complaint is some defect, and she was feeling that her eyes were a little pushed towards one side. So that is why she kept ignoring it until and unless there was proper proptosis. So it happened gradually. It happened over months. So that is why it was neglected by her. And only when the proptosis started occurring, and when the cosmetic deformity of the eyes bulging out was too much and was very easily noticeable, that she considered consulting me. And it is that time that when we got a CT scan done, there was a lot of intracranial invasion and it has spread a lot. The patient was started on voriconazole. It is a highly expensive medicine, and the surgical debridement was done not once but twice, but still the patient survived for nearly a year, where there was recurrence again and again, and we lost the patient. So the presentation is initially like chronic sinusitis, and later on it is slowly progressive. It will lead to proptosis, mass in the cheek. Diagnosis is by biopsy. And the management is surgical debridement. And along with that, we have to give antifungal. Yes, so we are seeing that antifungal management we are giving in invasive. Yes, so antifungal, voriconazole, or also itraconazole can be used. So now we know that when the fungus goes inside the body, how the presentation can be. It can be either a fungal ball, allergic fungal sinusitis, it can be acute invasive, it can be chronic invasive. What the features of each one of these are, we have seen them in detail. How we manage all of them, we know. How do you manage fungal ball? Yes, just by FES. Allergic fungal sinusitis? Again by FES. Invasive, we have to give, immediately start the patient on IV amphotericin B if it is a acute invasive. In chronic invasive, we have to go for voriconazole. So that is what you need to know in fungal sinusitis.